Hi guys, welcome back. We shall now be talking about ARDS, that is acute respiratory distress syndrome. So let us now study that why in this condition do you have what is called as a non-cardiogenic pulmonary edema. Let's knock some sense into these terms like cardiogenic and non-cardiogenic pulmonary edema. And what I'm first trying to represent before you is what is called as cardiogenic pulmonary edema, which could be occurring due to conditions like mitral stenosis or cardiomyopathy or myocardial infarction. In this diagram, I have shown that unfortunately the person is having a sudden onset left ventricular failure. So you can see that the pressure in the left atria will also begin to rise because the blood after all has to go from the atria to the ventricles. And if the pressure of the ventricles will rise due to failure, then left atrial hypertension will occur. Because of this left atrial hypertension, there would be congestion in the pulmonary circuit. And therefore the patient will be having what I can say simply as cardiogenic pulmonary edema. One of the highlights of cardiogenic pulmonary edema is that the patient will be having a presence of left atrial hypertension. The basic pressure in the left atria would be increased primarily because there's a backflow that is occurring in this patient. By backflow, I do not mean the fact that there is an actual transportation of blood because there is no regurgitation, but the pressure situation will change in the heart secondary to LVF in a patient due to any etiology. Therefore, cardiogenic pulmonary edema, the characteristic feature is that there is an increased pressure in the left atria. But if imagine a person is having swine flu or bird flu and he did not get proper treatment, the swine flu virus will not say anything to the heart. It will directly damage the lungs. And the direct damage to lungs will result in development of what is called as non-cardiogenic pulmonary edema. So what is so great about swine flu and bird flu that they are contributing to pulmonary edema? Well, swine flu virus will damage the pneumocytes. One of the important cells that are damaged in ARDS, which occurs secondary to swine flu or bird flu, is damage to the pneumocytes, which constitute a chunk of the surface area of the alveoli. If the alveoli will collapse, there would be hypoxia, and hypoxia in turn will damage the endothelial cells. The endothelial cells will become leaky. Therefore, when we study the pathogenesis of non-cardiogenic pulmonary edema of ARDS, we always study regarding leakage of fluid from the pulmonary capillaries into the alveoli of the patient. This circle here represents the alveoli, then is the surrounding blood vessels, and you can see that these blood vessels have become leaky. There is leakage of fluid, which normally does not happen in you and me. See, if a person is having a cardiogenic pulmonary edema, then there is increase in hydrostatic pressure in the blood vessel. That will cause transudation of fluid. But here I'm not saying that there is any transudation of fluid due to increase of hydrostatic pressure in the blood vessel. The pressure in this blood vessel of the blood vessel which is surrounding the alveoli is perfectly normal. But still, because of damage to the gap junctions which are present between the cells, because of the integrity of the endothelial cells getting impacted, there is a pulmonary edema developing in a patient. I would like to call this non-cardiogenic pulmonary edema. So the highlight of ARDS is that it is an example of a non-cardiogenic pulmonary edema. This condition will be occurring in approximately 10% of total ICU patients. So before we go into the technical definition of acute respiratory distress syndrome, as a broad perspective, I would like you to remember that if a person is having sudden onset respiratory distress due to various triggers that I'll be explaining to you, the triggers can range from swine flu pneumonia to toxic gas inhalation to aspiration of stomach acid. But if a person is having a sudden onset respiratory distress with chest X-ray finding of bilateral infiltrates which cannot be explained from the cardiogenic perspective, in a sense that person is not having any bat wing edema, there is a presence of demonstrable hypoxia in the patient, and a person is having normal left atrial pressure. Mark my words there. When I started this topic, I taught you that if a person is having cardiogenic pulmonary edema, there will always be increased pressure in the left atria. But in acute respiratory distress syndrome, which could occur due to conditions ranging from swine flu, bird flu, Mendelssohn syndrome, and many others that I will enumerate before you from MCQ perspective, if you read regarding chest X-ray having bilateral infiltrates, which might look like that of a cardiogenic pulmonary edema, might look like, not exactly cardiogenic pulmonary edema, might look like cardiogenic pulmonary edema, there's a demonstrable hypoxia, but the pressure of the left atria is normal, then we say it is ARDS in a patient. Please appreciate the fact that in ARDS, the damage is directly in the lungs. The heart is not involved. That is why the keyword that is most important for you to relate as a doctor is non-cardiogenic pulmonary edema. It is a highlight of this particular disease. Based on this baseline information, we will now study regarding what are the triggers which can contribute to acute respiratory distress syndrome in a patient, and they've been artificially classified as direct triggers and indirect triggers. Well, when it comes to the direct triggers, the simplest understanding that you can have is presence of pneumonia in a patient. It could be viral pneumonia, it could be bacterial pneumonia, but there is definitely an insult to the lung parenchyma, damage to the alveoli, and the damage is so extensive that it is resulting in development of even a pulmonary edema. Please appreciate, normally pneumonia you only have pus. But as the disease becomes more severe, as you have necrotizing pneumonia or you have a swine flu virus which is causing damage to the pneumocytes, damage to the endothelial cells, then the fluid that leaks into the alveoli will form a membrane. That membrane will coat the alveoli from inside and will prevent transportation of gases, and the hypoxia of the person will keep on deteriorating. And even if you give 100% oxygen, though obviously we should not give 100% oxygen because of oxygen toxicity, the oxygen saturation of the patient would still not be maintained. The second best example is aspiration of stomach acid. Let us imagine a person is being intubated. He is a patient who is under, or he is scheduled for a elective surgery. He is scheduled to undergo a open cholecystectomy, and right at the time of administration of GA, before the patient is administered general anesthesia, during the intubation process, the anesthesiologist was a first year resident. He was not very skilled. He was fiddling around with the procedure, and when he was trying to intubate the patient, the person vomited, and the stomach of the patient was empty, but it will still be having stomach acid. So the acid will go in the lungs and it will cause chemical pneumonitis. So Mendelssohn syndrome is one of the causes for direct injury to the lung and a development of ARDS in a patient. Another example that you can relate to is toxic gas inhalation. You see, way back in 1980s, there was an industrial disaster in India by the name of Bhopal gas tragedy. The people in the city of Bhopal woke up to inhaling some fumes that were leaking from the Union Carbide plant. That gas was methyl isocyanide, and when it went into the lungs of the patient, it damaged the pneumocytes, it destroyed the integrity of the alveoli. Obviously, there was no antidote for that, and thousands of people died. That is the worst industrial disaster in the world, and people who suffered at that point of time have still not got compensation. Obviously, it's a mean world out there, but basically what I'm trying to explain is the doctors at that particular point of time were struggling to find antidote. There would be no antidote because if you damage the integrity of alveoli, the patient is gone forever. I mean, the basic gas exchange would definitely not occur. Another reason that can be remembered is pulmonary contusion. Another can be near drowning. The highlight of all the conditions that I'm explaining to you is alveolar damage in the patient to the level that the integrity of the alveoli is gone and there would be a collapse of the alveoli or atelectasis. When it comes to indirect causes, then one of the important causes that is to be remembered is sepsis. You see, in earlier times, he just used to say sepsis is one of the leading causes, but now he is saying the fact, one, that direct causes are more common than indirect causes. We have now gradually realized the fact that conditions causing pneumonia, Mendelssohn syndrome, toxic gas inhalation, these conditions are having a pre-existing lung insult, and the mortality in direct causes is also higher as compared to the mortality of the indirect causes. So in the older edition of Harrison, there was a blanket statement, sepsis is the leading cause of ARDS. Now he has said the word pneumonia and sepsis are the leading causes. So suppose in an exam, you are having pneumonia also in choices and sepsis also in choices. I'm quoting Harrison 20th edition here because they written pneumonia first and then sepsis. So in this edition, he has basically made a slight twist in the data in a sense that they would have found that the incidence is relatively higher. So pneumonia and sepsis are two of the important causes. The next cause to be remembered is trauma, and when I say the word trauma, he might say multiple bone fractures. Now, when you read multiple bone fractures, the first thing that comes in the mind of most of the doctors is straight away a fat embolism. Please appreciate that fat embolism will take some time to appear, and we require good criteria for diagnosis of fat embolism. And in fat embolism, most of the time, the chest X-ray is normal. But in this case, there would be extensive fluoride infiltrates, and the manifestations can develop as early as 12 hours. So if you are having a question regarding multiple bone fractures in a patient, or he might not say multiple bone fractures, he might say that this is a construction worker. He was working at the site when a cement bag fell on the chest of this guy. The cement bag fell on the chest of this guy. The extensive weight on the chest will fracture his ribs at multiple sites. That is flail chest that can contribute to this. It could even be head injury. after which the person could be having a development of sudden onset respiratory distress. It could even be a person of burns. So please appreciate the fact that he could be giving any of the triggers where you might suddenly start thinking that this person who's having a flail chest or person who's having multiple fractures could be having fat embolism. But then it is ARDS which usually develops earlier as compared to that of fat embolism, and incidence wise fat embolism is even a more rare condition, whereas for ARDS as I said 10% of ICU patients can be admitted with a diagnosis of ARDS, or diagnosis is made by the first or second day of admission due to various reasons. The next indirect cause, and an important one to be remembered for the exam, is multiple blood transfusion. In fact, the term that could be used by the examiner sometimes is TRALI, that is transfusion related acute lung injury. I can squeeze in a MCQ here. If he says what is the leading cause of death that occurs after a blood transfusion, then do not answer mismatched blood transfusion. Yeah, that can also happen, but incidence wise the leading cause of death after blood transfusion is not mismatched blood transfusion. Do not answer hyperkalemia, do not answer metabolic alkalosis. The leading cause of death is TRALI, that is transfusion related acute lung injury, which in a sense is ARDS only. Then when you will read about the literature of acute pancreatitis, or when you read about Apache scoring with respect to pancreatitis, you will also read regarding that person of pancreatitis could be having ARDS. That's because of release of pancreatic enzymes into circulation that damages finally the blood vessels of the lungs. The last cause could be post cardiopulmonary bypass. So you have to remember all of these causes, and one of the common things that is linking all of the causes that I mentioned before you, the direct one and the indirect one, is that there is a definitive insult to the alveoli of the patient directly. So we are going to call it a non-cardiogenic pulmonary edema. Since the insult is directly in the alveoli, heart is not involved. Sometimes he might say which of the following, or he might say all of the following are causes of ARDS except. Most of the time, the fourth choice in that MCQ of except will be status asthmaticus. Please appreciate that asthma is not a disease of the alveoli, it is a disease of the conducting airways. So acute asthma exacerbation, status asthmaticus, severe persistent asthma, disease of the conducting airways is not ARDS. That can cut off blood supply. You see, you would have read regarding, or you will when you go through the asthma section, you will hear me saying the word silent chest and severe hypoxia. So asthma is a disease which mainly affects the conducting airways, and it is not an example, mark my words there, it is not an example supporting a crosshair, it is not an example of ARDS. Causes of ARDS are the ones which are mentioned here, are direct or indirect alveolar injury. One of the highlights of this entire discussion that you have to understand is alveolar damage directly. So that means that the left atrial pressure is normal. The term that will be used will be non-cardiogenic pulmonary edema. And as we progress in the discussion, I will explain to you how would you differentiate on X-ray cardiogenic and non-cardiogenic pulmonary edema. We will now look at the profile of the patient, how the patient will present to you. The patient will first present in the exudative phase, which will usually last between 0 to 7 days. And if the patient is lucky, he will then go on to the next phase that is called as proliferative phase, that is dependent on the skill of your management. Now in the exudative phase, if a person is having any of the triggers that I have explained to you on the previous slide, then the symptoms can begin with a time frame of anything between 12 to 36 hours. Before I go forwards and describe what is going to happen in the exudative phase, please appreciate the fact that if you get a question which talks about fracture of the long bone like that of femur, and then he says that person after 24 hours or 48 hours is deteriorating and is having sudden onset distress, he's going into coma, he's having fat globules in the urine, then obviously the answer is fat embolism. But if he talks about bone trauma, multiple bone trauma, and then says that as early as 12 hours, even before the person could be taken up for surgery, there is a development of sudden onset distress in the patient, and he has sustained injury to the chest, pulmonary contusion, for example, multiple rib fractures, flail chest, polytrauma, fracture of the femur also, and as early as 12 hours is deteriorating, then we should mark in favor of acute respiratory distress syndrome on clinical grounds, because that is how it presents. Usually as early as 12 to 36 hours after the trigger, the symptoms will start developing in a patient, and the exudative phase will last for 7 days. And if in these 7 days you are able to manage the patient effectively, then he goes into proliferative phase that lasts from 7 to 21 days. Now what's the problem in the exudative phases? Let me say this is representation of alveoli. Surrounding this are blood vessels, which would be lined by endothelial cells. When it comes to alveoli, the cells which are present are called as type 1 pneumocytes, which constitute about 90% of the surface area. You are aware from physiology that if they say that what is the most abundant cell of the alveoli, then the most abundant cell of the alveoli is type 2 pneumocyte. That's the one that is producing surfactant. ARDS is not to be taken as a adult version of hyaline membrane disease. You see, in hyaline membrane disease in babies, there is a problem with type 2 pneumocytes. The surfactant production is lesser, but surfactant producing cells, type 2 pneumocytes, are not affected in ARDS. It is type 1 pneumocyte that contributes the max to the surface area. Just to set the record straight, I would like to highlight the fact that type 2 pneumocyte is overall the most abundant cell of the alveoli. But if he says surface area, that is max surface area is covered by, the 90% of the surface area is covered by type 1 pneumocyte, and this is the major cell which will be affected in acute respiratory distress syndrome. Due to this, what's going to happen is that the alveoli will simply collapse. So I have here shown a damaged alveoli before you. Lining the alveoli is surfactant, which is produced by type 2 pneumocytes. So I have not shown any significant reduction in the surfactant production because type 2 pneumocytes are usually not affected, but I have shown that the surface area available for gas exchange is lesser. Due to hypoxia, the blood vessels which are surrounding this area will also begin to constrict. So you can once see in the patient that there is a beginning of a ventilation perfusion imbalance. Ventilation because the surface area which is available for gas exchange is getting compromised. The perfusion defect is coming secondary to the hypoxia component because pulmonary blood vessels, when they're exposed to hypoxia, they constrict. Here I would like you to remember specifically and pay attention to the fact that hypoxia causes dilatation of all blood vessels in the body except the pulmonary circuit. Please appreciate, like if you go to a hill station, you go to Leh or you go to Ladakh, at high altitude when you will go, because we are usually more adapted to living in plains, when you take a flight and you suddenly land at Leh or Ladakh, due to hypoxia, your cerebral blood vessels will dilate. That can cause headache. So if you have really been to a high altitude, you can better understand what I'm talking about. The headache symptom develops because the cerebral blood vessels dilate. So hypoxia causes dilatation of all blood vessels in the body. Why? Because dilatation will ensure more blood supply. So all blood vessels in the body dilate in response to hypoxia, but not the pulmonary circuit. The pulmonary circuit rather tends to constrict. So I've shown a pulmonary constriction occurring here, and because of the pulmonary constriction, the perfusion of the lungs will also become lesser. Now comes the most critical event. Here I have shown endothelial cells which are lining the alveoli, and these cells are very vulnerable to hypoxia. In a multiple choice question, they have asked which is the most vulnerable cell or the most damaged cell in patients of ARDS. Then do not answer type 1 pneumocyte. The major damaged cell is endothelial cells of the alveoli. These endothelial cells will now become leaky in a sense that the junctions between them, the gap junctions between them are damaged, and therefore there could be a leakage of fluid between these gap junctions. And now I have shown proteins leaking into the alveoli of the patient. So in this person, I have shown that the pressure in the blood vessels surrounding the alveoli is normal. In congestive heart failure, the hydrostatic pressure of the blood vessels will increase and there would be transudation of fluid. But this that I'm showing before you is an exudate. Why I'm saying it is exudate is one, it occurs secondary to an infection. You all know that infection contributes to exudative situation. So this particular chap is now having a development of high protein pulmonary edema. Exudate always has more protein, transudate has less protein. So in multiple choice question, he might say the word high protein pulmonary edema. You have to appreciate the fact that whenever there is a heart failure, there is increased hydrostatic pressure that results in development of low protein pulmonary edema. But in persons having ARDS, the endothelial cells become leaky, the fluid leaks, the proteins also leak. So therefore there is a development of high protein pulmonary edema, and this high protein can basically form a layer. This is the protein forms a layer inside the alveoli, which further worsens the hypoxia. The gas exchange is definitely compromised. Coming to the features of the disease, in most of the MCQs, he will first describe to you the exudative phase of the disease, which can begin as early as 12 hours to 36 hours after the trigger, which could be ranging from swine flu pneumonia to acute pancreatitis in a patient. After the exudative phase, the person will pass into what is called as proliferative phase. If he is lucky, recovery will occur. But in some patients, there might never be a permanent recovery because there would be so much of insult in the lung that though you have made him survive thanks to your ventilation skills, the person will develop a fibrotic phase. The exudative phase of acute respiratory distress syndrome lasts between 0 to 7 days. The proliferative phase will go up from 7 to 21 days, and after 3 weeks, there would be fibrosis which would be occurring in the lung parenchyma of the patient. The features for the exudative phase could be written in the MCQ in the following sense. I am reiterating my statement. Within 12 hours of the trigger, or 36 hours of the trigger, there is a development of sudden onset respiratory distress. Now, instead of saying the word respiratory distress, which will make it easy for you, the examiner will try to play around with English and use the word intrapulmonary shunting. That simply means that blood is getting wasted in the lungs. There are two reasons for it. One reason is the ventilation problem, that the alveoli have collapsed, so the surface area for gas exchange is lesser. Second, because the damage to the endothelial cells, when the proteins will leak, there would be a high protein pulmonary edema. The proteins will form a layer inside the alveoli that will further impair the transportation of gas. So blood is going in the lungs, but it is not getting oxygenated, and gradually the pulmonary vessels are also constricting. So combination of everything that I said, there's a ventilation problem, there's a perfusion problem. He will say the word intrapulmonary shunting as one of the choices for this condition. The work of breathing of this person is increasing, so respiratory muscle fatigue will set in. Obviously, hypoxia will cause hyperventilation in the patient. So diaphragm will work over time, sternocleidomastoid, scalenius group of muscles, alanine. Very soon the muscles will soon get tired. So work of breathing of this person will gradually start increasing also. The values of oxygen in the body will continue to fall. So he might say the word refractory hypoxia. Along with this, a very important thing that is mentioned is that due to continuous ventilation perfusion imbalance or increase in dead space ventilation, because the alveoli are collapsing, so increase of dead space ventilation, there is a development of increase in carbon dioxide in the patient. I reiterate my statement. The MCQ can use the word intrapulmonary shunting and increase in dead space of the lungs because of the atelectasis component. Therefore, there is a rise of carbon dioxide in the body. Therefore, acute respiratory distress syndrome in the current edition of Harrison has been mentioned as an example of type 2 respiratory failure. And therefore, because there is more carbon dioxide in the system, eventually that will produce more protons. So it will result in generation of respiratory acidosis in a patient. You see, initially, when there is a development of pneumonia, he will breathe fast. That will cause carbon dioxide washout from the body. So initial presentation will definitely be that of respiratory alkalosis. But finally, as the person tends to deteriorate, there is a rise of carbon dioxide due to increase of dead space. So subsequently, there would be a type 2 respiratory failure with acidosis occurring in a patient. So usual query of most doctors will be, then what should you answer? First of all, I want to highlight that in all lung diseases, similar kind of presentation can be seen. Like when I teach you acute asthma causes hyperventilation, that is type 1 failure. And when acute asthma deteriorates into status asthmaticus or silent chest, then carbon dioxide starts rising in the person. Then person goes into respiratory acidosis. So the bottom line is, if respiratory diseases are evaluated at the starting of the illness, you have a carbon dioxide washout. The same person, when he deteriorates because you could not manage him effectively, then he deteriorates into type 2 respiratory failure. Given a situation between what should you answer for acute asthma, it is respiratory alkalosis and type 1 failure. Why? Because there's a carbon dioxide washout, fast breathing. In status asthmaticus and silent chest, there is type 2 respiratory failure. Similarly, in ARDS, in initial presentation, when there's only a swine flu pneumonia, it would be respiratory alkalosis developing in a person. But as there is a collapse of the alveoli of the patient, there is a ventilation perfusion imbalance setting, then subsequently there's a type 2 failure. Still, let me say, he has not given you any description, early phase, late phase. He just says select one, then you have to select type 2 respiratory failure for the patient, because ultimately in respiratory diseases, the value of carbon dioxide will rise, and that will result in final mortality of the patient, because once the PCO2 hits about 60, then even compensation mechanisms will fail. And that's again an important point for you to remember, that when PCO2 hits an upper circuit of 60 millimeter of mercury, then the chances of survival in the patient will definitely go down, and the compensatory mechanisms will also begin to fail in the patient. When it comes to the proliferative phase, most patients, you will be able to wean off the ventilator I'll also talk about the ventilator strategy that you will use for these patients. But thanks to your good ventilatory support that you ensured, and I mean, the only thing that is between death and the patient is you as a doctor with a ventilatory support. Had you not provided this ventilatory support, he would have anyway expired. So, in the proliferative phase of the disease, what you will have will be, histopathologically speaking, there will be, why we call it proliferative phases, because the damage in the lungs will now cause proliferation of type 2 pneumocytes. Now, why that is important is because of the fact that, one, they are trying to obviously limit the damage. I mean, whatever surface area damage is damage, but you are trying to contain the damage which is present in the lungs of the patient. So, the proliferation of type 2 pneumocyte, and the next thing that I say is very, very interesting. He has said the fact that some of these type 2 pneumocytes will then differentiate into type 1. You see, earlier the concept was that once the lung is damaged, there is no possible of recovery. But look now, what is the surprising thing that he's saying? He's saying that type 2 pneumocytes can differentiate into type 1 pneumocyte in a patient. So therefore, the body is trying to repair the damage that was initially caused by the various triggers or the inserts that I mentioned before you. And therefore, earlier we were of the impression that if somebody has had ARDS, is gone. But now we are saying, thanks to the ventilation strategies that we are using, we are able to save these patients, and that is because of obviously the improvements in the technology that we have. We have better ventilators, we can get better fine control of the respiratory dynamics, but then the lungs also play a role. Look at the healing powers of the human body. The type 2 pneumocytes are differentiating into type 1, and therefore the damage in the lung is definitely contained. In some of the patients, they might go into a stage of lung fibrosis, so therefore the lungs of the person will begin to reduce. When it comes to person having fibrosis, then they might require supplemental oxygen for whole of their life. The requirement of supplemental oxygen might vary from case to case. Some patients might be having only a requirement with help of a nasal cannula. Some might require ventilation for remaining whole of life. You might have to do a tracheostomy in the patient. That depends upon case to case. But he says that if pulmonary fibrosis will start occurring in a patient, then there will also be a development of pulmonary artery hypertension. So most patients of ARDS, if they survive, they will suffer from sequelae of PAH that will develop in the patient, interstitial fibrosis that will occur. And he also says a very interesting thing, that the damage that has occurred in the alveoli of the patient and the bronchioles of the patient, which are adjacent, can even result in formation of blebs and bullas in the lung. Remember, bulla is something that I've taught you in emphysema, that bulla is also mentioned in the literature of ARDS in the current edition of Harrison. So if he wants to trouble you in a pathology question, do not be surprised if he mentions the word bulla and fibrosis both. See, both don't gel together. Bulla is a feature of COPD, fibrosis is a feature of pulmonary interstitial lung disease. Here I am saying ARDS MCQ can be having bulla written also and fibrosis also written from pathological domain, because the insult to the lung parenchyma has resulted in these manifestations in a person. Most MCQs might just use a broad term like sudden onset respiratory distress, or he will use some special terms that I will mark before you now, which are important from the exam perspective. One is this word intrapulmonary shunting is a feature of acute respiratory distress syndrome. There's wastage of the entire blood supply. The entire thing of what the lungs do is not being fulfilled here. The basic function of lungs is simple: send in oxygen, diffusion of gas, oxygen being carried by the RBCs, and well, that's a normal happening. But here the normal happening has been affected. Then there's a development of type 2 respiratory failure in the patient. That's a very marked shift that he has mentioned, highlighted in this book. Earlier, he used to always, mention about presentation of hyperventilation, but he used to be quiet regarding carbon dioxide values. And a lot of people wrote to the editors of Harrison, including myself, that you have not mentioned regarding what's going to happen to the carbon dioxide values in the person. And well, in this edition, they have responded to our queries by mentioning the fact that the values of CO2 in the patient will begin to rise. Then is another factor, that is differentiation of type 2 pneumocyte into type 1 pneumocyte. This type 2 differentiation into type 1 pneumocyte is why the recovery in this person is definitely possible. Let us now talk about what will you do for workup of these patients of acute respiratory distress syndrome. The first and the baseline investigation that would be done would be a chest X-ray. My students have sat for the previous exams in which ARDS has been asked. They have told me the fact that the X-ray was so wide that they could not even make out the blackness of the lung parenchyma. You see, this is what they told me. I have here summarily represented bilateral pulmonary infiltrates in the patient that none of the normal blackness in the lung parenchyma can be appreciated. Now keep your eyes on the slide and follow my words very carefully. In a different exam at a different time, my student reported that he got an X-ray in which the heart was looking relatively bigger. Like in this case, I have tried to show relatively a presence of a cardiomegaly. He also said that the lungs were totally white, but he noticed that the whiteness was mainly present around the cardiac borders or cardiac silhouette. I have trying to show a silhouette sign coming up here. The whiteness is extending out from the lung parenchyma. Obviously, when the whiteness will increase, it will involve extensive lung parenchyma, but you can see here that I'm trying to show presence of a cardiogenic pulmonary edema or a bat wing edema, whereas in the superior diagram you can see that I've shown sparing of the pericardic areas. I have now also shown presence of bilateral pleural effusion in the patient. Let me just exaggerate it a bit, the pleural effusion component in the patient, which will cause blunting of the CP angle. And you will realize the fact that in the inferior diagram that I made before you, the cardiothoracic ratio of the person is shown to be increased. Normal cardiothoracic ratio in you and me is 0.5. Heart occupies 50% of the space in the chest. In this person, the CT ratio is enhanced. Then you can also see bat wing edema developing in the patient. There is a characteristic paracardiac whiteness present, and the cardiophrenic angles of the patient are blunted because there is a presence of bilateral pleural effusion in the patient. But in the superior X-ray, you can see that I've tried to show CT ratio being normal. There is a very clear-cut paracardiac area which is not involved in the patient, and also the CP angles of the patient are perfectly normal. Whenever in an exam they are giving you whiteness in the chest X-ray which is suggestive of pulmonary infiltrates and a pulmonary edema, in a 30-second MCQ, what you will do will be that you will dedicate 10 seconds to look at the heart size, 10 seconds for CP angle, and then 10 seconds for whether the pericardic areas are involved or not. And if you find them to be normal, then the superior diagrammatic representation that I made before you is that for non-cardiogenic pulmonary edema, since the heart is not involved. However, in case you get an image which I have just shown inferiorly to you, then you will call it cardiogenic pulmonary edema. Most of the time in the exam they will give you image of cardiogenic pulmonary edema because that is relatively more common a presentation in our casualties. So our consultants will be having X-rays of mainly cardiogenic pulmonary edema that they will show in the exam. But what I said was that is only to be answered when you are not able to make up these points. Otherwise, obviously, you will have to differentiate. And let me show you the two X-rays so that you can relate to them better. If you look at the X-ray that I have shown currently where the markings are given, one I would like to highlight the fact that the size of the cardiac border looks relatively dilated, whatever that can be made of. There is a blunting of the CP angle. There is definitely a pleural effusion which can be present in the patient. In doubt, I can obviously do an echocardiography, which will be an important tool for diagnosis of this condition because echocardiography in cases of cardiogenic pulmonary edema will definitely show a reduced ejection fraction in the patient. Echocardiography will also show that the pressure in the left atria of the patient will be elevated, but when it comes to X-ray, then you will notice that there is presence of bilateral infiltrates which are spreading out from the lung parenchyma in the patient. However, in the other image, you will notice that the heart looks normal. The CP angle, though it's a little cut out in this image, is normal. So I have here shown normal costophrenic angles, no blunting of the CP angles. The cardiothoracic ratio of the patient is also normal. There is obviously bilateral infiltrates in the patient. And let me say from the exam perspective, I'm just creating a report before you that the echocardiography of this person is showing an ejection fraction of 65%. And when we measured the pressure in the left atria of the patient, the left atria pressure was normal. Based on the information provided, you can see the fact that the left-hand side of this discussion, where left atrial pressure is normal, ejection fraction is normal, cardiothoracic ratio is normal, we will say that the person is having a presence of a non-cardiogenic pulmonary edema. The left-hand side is diagnostic or is suggestive of non-cardiogenic pulmonary edema. Whereas for the right hand side, I don't need to write, it's understandable. There is findings written here with a battering appearance, with blunting of the CP angle in the patient, elevated left atrial pressure. So that goes in favor of cardiogenic pulmonary edema. So echocardiography also plays a role in diagnosis of these particular patients along with chest x-ray. Supporting that, I will also be doing in these patients ABG. So let's just summarize the investigations which I have just done in the person. I've done a chest x-ray, I've done an echocardiography to rule out the cardiac aspect, I have done an ABG in a patient, and then I can definitely confirm that it is ARDS in a patient. The findings of the chest x-ray to be remembered are bilateral extensive infiltrates. CP angle blunting may or may not be visible to you in the exam, and lots of time my students have told me that in a pressure cooker situation the brain was not working. So it's okay, I understand under pressure you may not be able to relate to CP angle blunting, etc. But if you see bilateral infiltrate, then you have to see the surrounding information given to you, like echocardiography mentioning a normal ejection fraction with left atria pressure being normal, which I have highlighted right from the beginning of this discussion. Why? Because in the older version, like in the last year version of the app, you would have noticed that according to the 19th edition of Harrison, I was saying the word that PCWP, pulmonary capillary wedge pressure, should be less than 18 millimeters of mercury. But today I've not even used the word PCWP, because in the current edition, he has simply said the word normal left atrial pressure instead of using a technical term like pulmonary capillary wedge pressure. Then measuring it, he just says measure the left atrial pressure. That's more straightforward. The ABG of these patients will reveal ventilation perfusion imbalance representing type 2 respiratory failure. So these are investigations which are done in acute respiratory distress syndrome, which was also earlier referred as acute lung injury. Based on whatever I have said, the final summary that you have to understand, or essentials or diagnosis that you have to understand, is whenever you read regarding sudden onset respiratory distress question. Now suppose a question is saying person is having sudden onset respiratory distress after putting a central line. Then obviously I am not talking about ARDS in a patient. Then I am talking about development of pneumothorax. So the question has to be read in the right perspective. Sudden onset distress in a person with the center after central line insertion is a diagnosis of pneumothorax. Let's try this once again. A question says there is a sudden onset respiratory distress in a patient of Staph aureus pneumonia who is on vancomycin for 2 days. The person of Staph aureus pneumonia is already under your care. The person is already receiving intravenous vancomycin for 2 days. And just now, 5 minutes ago, when you went for round, you talked to the patient, he said, I'm fine. And just now the relative came running and he said, sir, please have a look. My brother is totally blue. And when you went to the bedside, you were surprised like 2 minutes ago, or 5 minutes ago, or 10 minutes ago, when you took the round, when you spoke to this guy, he himself told you, yeah, doctor, I'm better. Or you noticed he was eating his lunch. He's better. You were planning a discharge of this person of pneumonia who initially was obviously sick. So you had admitted him, but now he's recovered and he was talking to you, and now suddenly he's blue. Within 5 minutes turned blue. Well, what happened? What happened here was again a pneumothorax, because you know that Staph aureus can contribute to development of damage in the lung parenchyma by the name of pneumatocoel. This pneumatocoel could have ruptured any time, and because of that pneumatocoel rupture, there would be communication developing between the lung parenchyma and the pleural space. The pressure of the pleural space will change, and there would be a development of pneumothorax. So sudden onset distress after central line insertion and sudden onset distress after Staph aureus pneumonia person on antibiotics, yes, he's speaking to you and within 5 minutes deteriorated, that is definitely a pneumothorax. But if you read a question like this, sudden onset respiratory distress in a person of multiple bone fractures or after blood transfusion in a person, then you know that you are thinking in terms of acute respiratory distress syndrome in a patient. This finding of sudden onset distress in a patient, or clinical findings that should be given in the patient, should be supplemented with a chest x-ray showing bilateral pulmonary infiltrates. Now I will come to the most important part of the discussion of ARDS, which is a term by the name of PaO2-FiO2 ratio. PaO2 means partial pressure of oxygen in the blood vessels. FiO2 means fraction of inspired oxygen. PaO2-FiO2 ratio less than 300 is one of the most important diagnostic criteria for ARDS. There should also be a concomitant absence of left atrial hypertension or increased pressure in the left atria. These four that I mentioned before you are the diagnostic criteria for acute respiratory syndrome, acute respiratory distress syndrome. In earlier times, doctors were under impression that this condition is an adult version of hyaline membrane disease. Hyaline membrane disease affects type 2 pneumocytes, and in this disease, it is endothelial cells and type 1 pneumocytes that are affected, so it is not an adult version of hyaline membrane disease. The essentials of diagnosis of acute respiratory distress syndrome to be remembered are these are the data that should be given in a question. That is when you will say ARDS, like he says, a person has been admitted or is on currently treatment with swine flu and suddenly he is having extreme breathlessness that he came to the hospital in the casualty in the night and you demonstrated these four things, it is ARDS. Or a person after multiple blood transfusion is having a development of respiratory distress, or a person who's been admitted with the diagnosis of acute pancreatitis is having falling in oxygen saturation and you demonstrated these four things together, then you will say that the person is having acute respiratory distress syndrome. The former term was acute lung injury. He has also mentioned the grading. The grading is that if the PaO2 FiO2 ratio that I have just enumerated, PaO2 is partial fraction of oxygen in the blood vessel, FiO2 is fraction of inspired oxygen. If it is less than 300, he will say mild ARDS. If it is less than 200, it is moderate ARDS. And if it is less than 100, it would be severe ARDS in a patient. This that I've just explained to you is described in the textbook as Berlin criteria for diagnosis of acute respiratory distress syndrome. One of the highlights of the discussion is this terminology. Obviously, all of them are to be remembered. But if you get this slide imprinted into your brain, well, I can just say like this, doctors are supposed to have a photographic memory. Everything that I'm saying, it should be imprinted into your brain so that you can relate and go back and solve multiple choice questions. But then this I would rate as the most important slide for this topic, that if you know this slide, that you are bang on target for understanding this topic. Now, once you identified this condition, it is time for treatment. We have learned the hard way that for management of this case, we are not supposed to do a traditional. We normally used to do a intermittent positive pressure ventilation, but with practice, we doctors have realized that we are not supposed to go in for a standard ventilation of these patients because barotrauma can occur. The alveoli are already damaged. If you will fill air into those alveoli which are already inflamed, already damaged, then volume trauma can be occurring, and that will definitely mean that you are causing pneumothorax in a person. So, for management of this patient, the treatment of choice or the ventilator strategy of choice is low volume ventilation. Mark my words there, I did not say low flow oxygen. I'm not talking about low flow or high flow. I'm talking about low volume ventilation. What I mean by this is that normally when we set up the tidal volume on the ventilator for a person, in routine cases, like let me say a person is having myasthenic crisis and a person is having diaphragmatic paralysis, hypokalemia patient is having diaphragmatic paralysis, Guillain-Barré syndrome is person is having diaphragmatic paralysis, then the tidal volume is set at 12 ml per kg of body weight. But in this condition, the tidal volume will be kept at 6 ml per kg to minimize the chances of barotrauma or volume trauma in the patient. So low volume ventilation is the mainstay of treatment for this person. Normal tidal volume is 12 ml per kg when a person is on a ventilator for conditions ranging from Guillain-Barré syndrome, transverse myelitis, cervical cord fracture contributing to diaphragmatic paralysis. Ventilate these patients at a lower volume so that you just want the alveoli to remain inflated so that at least some gas can diffuse. But if you try to push more air into the alveoli whose integrity is already damaged, then they will simply pop off like a balloon. Also, you have to ensure that the pressure which is generated inside the alveoli is not suddenly spiking. We generate a plateau pressure. You see, plateau, as you understand from English, would be that the pressure will rise gradually. It will remain static. It will not be a sudden spike in pressure and a decrease in pressure. It should be a plateau pressure that should be generated inside the alveoli or in the airways, and the value should remain less than 30 centimeter of water, right, not millimeter of mercury. The respiratory rate on the ventilator dashboard, you can control the respiratory rate, you can control the FiO2 if you see the controls of the ventilator. So respiratory rate should be kept at less than 35 per minute. pressure should not be spiking or decreasing suddenly. It should be plateau pressure constantly to cause recruitment of alveoli. But even the recruitment is just keep them open so that at least some gas will diffuse. So plateau pressure of less than 30 and low volume ventilation of 6 ml per kg is the main way to manage these patients. In the question, if he says what is the first step in management of these patients, answer is low volume ventilation. The second thing that you are supposed to do in these patients is nurse them in prone position. This is itself a challenge because normally in our intensive care unit, we keep all patients in supine position. They have endotracheal tube in place, they're ventilated in supine position. But prone position ventilation has been shown to be superior as compared to supine position ventilation for these patients. So therefore, prone position ventilation is always to be done in these patients, which will improve survival. And the biggest risk when you put the person in prone position is a risk of extubation. That is, the endotracheal tube might come out. So the anesthesiologist or the intensive care physician who is available bedside for the patient, he always on his every visit has to see that there is no problem with the endotracheal tube. The endotracheal tube should retain its position. Another risk is central venous line, the CVP line, because the person is lying supine due to pressure on the neck, distant turning of the neck. The CVP line may even be lost in the patient, or the CVP line might even come out and they might be bleeding from the side of the central line. So extubation, CVP line loss, and even orthopedic injury, which could range from compression of nerves because we are placing the patient in prone position, so there could be undue pressure on the arm of the patient, so there could be damage to brachial plexus. Therefore, orthopedic injuries can also be anticipated in the patient. So the nursing team and the intensivist team who is taking care of the patient has to ensure all these do not occur in the patient to ensure survival. Another strategy which is being used for management of this patient and was used in case of Tamil Nadu Chief Minister Jayalalitha. She was a powerful chief minister in Tamil Nadu, and unfortunately she expired because she had pneumonia and then she went into ARDS. So they flew in specialists from London to take care of her, though even Apollo Hospital Chennai was good enough to manage her. I mean, Apollo Chennai did a very good job in ensuring that she survived for that long, considering her cardiovascular status was very bad. But then extracorporeal membrane oxygenation was used in her. Extracorporeal membrane oxygenation is a new method of ventilation in those patients whose heart or lungs is too weak to ensure ventilation. I'll just show you an image of this particular patient who has actually got a lung transplant. But look, this is a very surprising image that I'm showing you. You can see two big tubes which are carrying blood, and see the color of the blood in the tubes is also different. So one tube is carrying oxygenated and the deoxygenated blood, which are from the heart of this particular person. So the heart and the lungs of this person are not functioning properly. This person has received a lung transplantation, and in this particular case, this is not an ARDS patient. This person has undergone a lung transplantation, but I'm just showing you the technique of ECMO, that is extracorporeal membrane oxygenation, where it is a machine which is maintaining oxygen saturation in the body, and because the lungs are so tired, they can't function normally. So we have used this technique, which is obviously a new one, and the results of this are not as good as low volume ventilation. So if extracorporeal membrane oxygenation is given in the choices, it is one of the strategies that we use, but the efficacy of this is lower as compared to low volume ventilation. The fourth thing that we need to do in these patients is limited amount of fluids. I don't want to limit fluids to the level that the urine output will fall, because I don't want dehydration and multi-organ failure, but limited fluids should be administered to patients of ARDS. Why is that so? Is because if you will load a lot of fluids into the body of the person, then the LA pressure will begin to rise, and there will also be a cardiogenic pulmonary edema coming in the patient due to volume overload. Remember, he is already having a non-cardiogenic pulmonary edema, but in this case, limited fluids, because I want to keep the LA pressure to be as close to normal as possible. Normally, in any person, if you give IV fluids, the IV fluids will cause the pressure of the left atria to rise. Here, I want the LA pressure to remain as normal as possible, or on the higher side of normal, but never exceeding status where the pulmonary edema component tends to worsen in the patient. So limited fluids and diuretics are used in these patients to maintain LA pressure on the normal side. So you're doing two things. One, you're pushing in fluid, you're giving also diuretics to maintain a balance so that the LA pressure, the left atrial pressure, remains normal. Otherwise, you will add insult to the injury. It is like adding fuel to the fire. He's already having a non-cardiogenic pulmonary edema. You increase the LA pressure, you will cause cardiogenic pulmonary edema in the patient. Along with this, you will also ensure neuromuscular paralysis. That's obviously important, so that if the person is sedated, you can ventilate the patient relatively better. Any routine drugs can be used, like one of the drugs that is used is cistracurium. But neuromuscular blockade in the patient is to ensure effective ventilation of the patient. So in the intensive care unit, if all these steps are being followed, then the chances of recovery of the patient is definitely there. And do remember that steroids do not have any role in management of acute respiratory distress syndrome. Some experts have even tried surfactant therapy initially, but they have failed miserably because this is not a deficiency of the surfactant. This was a very old approach that was tried, thinking that ARDS is a adult version of pediatric hyaline membrane disease. This is not the case, as I've explained to you. So you can relate to that surfactant therapy will not work in this condition. When I was a student at your age, the older edition of Harrison used to answer the best ventilator strategy for this person as a very special ventilator that was called as HFJV. HFJV stands for high frequency jet ventilation. It was a very fancy term, jet ventilation. I mean, normally we read about a jet engine. You sit in a plane, the jet engine helps you take off. And we read about a jet ventilator, so it's a very fancy term for us. But then studies have shown that high frequency jet ventilation has not met our expectations, and now this is mentioned as not recommended for management of these patients. Why I'm teaching you this is because the question can be asked as all are good or all are used for management of patients of acute respiratory distress syndrome, except so steroids, surfactant therapy, and high frequency jet ventilation has not been shown to ensure a better survival in the patient. Patients of ARDS can definitely expire. If he says, what is the leading cause of death in acute respiratory distress syndrome? Don't answer respiratory failure. Don't answer type 1 failure, type 2 failure. The number one cause of death in patients of acute respiratory distress syndrome should be answered as sepsis. Sepsis is also a trigger which can contribute to ARDS, but it is non-pulmonary causes. That's the line from Harrison again. Non-pulmonary causes are more important a cause of death in acute respiratory distress syndrome as compared to pulmonary causes in a patient. So instead of answering, respiratory failure is contributing to death. You see here the data is based on incidence only. That why did the person die? He died primarily because of septic shock which resulted in damage in the lungs. So the primary cause of death is sepsis. The most common cause of death in acute respiratory distress syndrome should be remembered as septicemia. To finish the topic, I want to teach you the fact that when it comes to congestive heart failure, when it comes to acute respiratory distress syndrome, both will be causing a pulmonary edema. In congestive heart failure, there will always be a transudative pulmonary edema in the patient because the pressure, hydrostatic pressure in the blood vessels of the lungs will definitely be increased, and also the pressure of the left atria will be increased. In acute respiratory distress syndrome, there will always be exudative pulmonary edema. The hydrostatic pressure in the blood vessels will be perfectly normal. The left atrial pressure of the patient will be always perfectly normal. Left hand side can be written as low protein pulmonary edema, but right hand side is an exudate. So in a multiple choice question, he will say high protein pulmonary edema occurring in the patient. On the left hand side, the values of BNP, B-type natriuretic peptide will always be increased. The values of BNP in acute respiratory distress syndrome will always be normal. The X-ray can be showing bilateral infiltrates in both the cases. The findings of X-ray, sometimes when the X-ray is totally white, it is very difficult to make out whether that whiteness is of the lungs or the whiteness is of the heart. So therefore, X-ray is not an absolute way to diagnose the condition. That is why the diagnostic criteria have come up. So let's look at the diagnostic criteria once again. The words are sudden onset distress following a trigger. The triggers are on the top. With obviously X-ray findings with PaO2 FiO2 ratio less than 300 and absence of left atrial hypertension or increased pressure is a diagnosis of acute respiratory distress syndrome. Then is classification of mild, moderate, severe. That is easy for you to remember: 300, 200, and 100 in a patient. And if he simply says what is the ventilator strategy of choice for this condition, then the answer is given as low volume ventilation superior to extracorporeal membrane oxygenation. And what does not work in this condition is jet ventilation, steroids, and surfactant. These are the details I want you to remember for this topic, which is important for the exam, because usually emergency medicine questions in the form of ARDS are usually asked. And ARDS is anyway, something that you have to know anyway, because once you join a job after, completion of your internship, ARDS would be like 10% of your ICU patients. So you have to take care of these patients. So obviously ventilator strategies I'll be discussing in a separate lecture, but then these are the steps which I would like you to remember for this topic. So keep working, guys, keep hammering, and I'm very sure you'll come out with flying colors. Thank you so much for listening.